Welcome everybody. Tonight's topic is TCA, traumatic cardiac arrest. So we are going to change your whole approach on how you resusc trauma patients. So, have any one of you heard this, saw this happening? Yes, no, maybe? Okay, great. Okay, so on the algorithm you got, just to run it through, because I see some of you are very old in the field, might not have saw this updates. Okay, so traumatic cardiac arrest comes from the ITLS guys and the TCCs and all these guys. They've designed the thing because we cannot run a trauma resusc like we run a medical resusc. It's different fields. We need to look at different things that takes priority over certain things. Okay, like for instance, with your AHA ERC courses, you'll do circulation, airway, breathing, start chest compressions as quickly, don't interrupt chest compressions, and airway and breathing when you do airway after 30 compressions. Okay. TCA changes the whole principle. So from your patient approach, from set on, arriving on scene, so your MOI becomes now vital important to evaluate your MOI. Stabbing, gunshot, car accident, pedestrian, any traumatic event. Okay. So you get onto a scene and this is a trauma patient. Okay, so your scene develops, trauma patient, and you get to your second step. And all your approaches is always circulation, airway, breathing. But in trauma, it changes to catastrophic bleeding. So arriving on scene, your patient is lying there. Okay? So as you approach, you go hazards, history, hello, help. With hello, you all already determine is this patient conscious or not. Okay? And then help, call extra help, police, whoever is needed. Then, before you go circulation, airway, breathing, you check catastrophic bleeding. So, how do we identify catastrophic bleeding on a patient? Okay, first off, you check for blood on the clothes. Okay, you check for blood actively flowing out of a patient. And you check for pools of blood lying around the patient. He might have stopped bleeding because he's in cardiac arrest. Heart doesn't pump, blood doesn't flow. Okay, so you check your catastrophic bleeding. So now address the catastrophic bleeding. Stop the bleeding. What's the quickest way to stop peripheral bleedings? Tourniquets. Okay. Put it on, stop it as quickly as possible. Don't struggle, bandages, whatever. Tourniquet for legs, tourniquet for arms, stop the bleeding. Okay? You have a junctional bleed. Okay? Groin area, shoulder area, neck. We pack, wound packing. Some of you, this is new, some of you, this is old. So wound packing is the new thing in. So hemostatic gauze is preferred, but if you don't have, because of price, normal bandages will work. So pack the wound as tightly as possible, as quickly as possible to secure the bleeding. Remember, applying pressure to that wound. So that means if my partner Elrin is packing wounds, she's out of action for this resusc event because she is applying pressure to that pack. Okay, so catastrophic bleeding sorted. Okay, now next one, airway. Is this patient having airway? So the airway, open, maintained, clear. Okay, so on basic, it's NPA, OPA, head tilt, chin, jaw lift. That is your procedure to open the airway. ILS, you will have your OPA, NPA. If there's massive facial trauma, needle crack is an option to go for. Okay. Please, in a traumatic event where you have facial trauma, significant facial trauma, crack the patient earlier than later. Okay, because that is your airway management until advanced, and then the next step will be taken. Okay, so airway sorted. Breathing, now we start chest ventilations. So this is definitely a back valve mask, patient's not breathing. Okay. Now you have ventilations going. Now there's no pulse. So feel a pulse, no pulse, start chest compressions. So comparing to normal CPR, you would have done chest compressions a whole lot earlier. But now we've sorted out bleeding, then airway, then breathing. And now only do we start with chest compression. It doesn't help you pump the heart while the container is open. So close the container, pump the heart to circulate what's left. Okay, so now we're pumping the heart. You are doing chest compressions, your ECG goes onto the patient, and you have your rhythm. Let's say it's a PEA rhythm, bradycardic. So what do you do, bradycardic patient? You check your H's and T's. So that comes to your patient where you are going to check your H's and T's. Medical H's and T's, there's about 5 H's, 4 T's, okay? And trauma H's and T's have brought it down to 2 H's, 2 T's. So hypoxia, that is your OPA, NPA, advanced airway management, oxygen provided, so hypoxia is being addressed already. Remember, if you don't stop bleeding, hypoxia, doesn't matter how much oxygen you give, is going to be problematic because you're losing blood, and blood carries oxygen. Okay. Then you have tension pneumo. While we're doing chest compressions, can we diagnose a tension pneumo? That's impossible to very slim to do it. Okay. So percussion, auscultation, that's not going to happen with that. So what do? We look at MOI, mechanism of injury. So is the injury relevant to chest injury? Seatbelt, needle decompression. But now we're not going to look which side is the injury. We're going to bilateral needle decompress. So if you needle decompress the right side, there's no air escape, leave a needle. Decompress the left side, air escape, well done, you're doing something. Okay. Remember, you're pushing the chest. We are using 14 gauge Jalcos. 14 gauge Jalco needle is about, the catheter is about 3.5 centimeters long. While doing CPR, the adipose tissue on top of his chest is going to push that needle out of a pleural space. So how do we address this problem? Okay, mid-auxiliary, fifth intercostal space on the sides. So now you can push the chest as much as you want, your needle is secure. It's not going to pull out. What's a simple, easy way to find the fifth auxiliary? Okay, grab the patient's hand, chuck it into the oxal. Where the little finger is, just find the mid-auxiliary line, and that's where your needle goes in. Okay, so needle decompress, air escapes. So that is your possibility. Now, because we did not distinguish between pneumothorax, you might needle decompress and blood comes out. Okay, if that happens, the needle will allow a little bit of blood to come out, but it will not be significant. So pull it out, leave it in, doesn't matter. Okay, just don't stick a second needle in. Good. Then we address the T's. There is no way pre-hospital, while pushing the chest, to have a cardiac tamponade. Okay. You can diagnose it on a monitor. It does become difficult while somebody's pushing the chest. But we are not going to transport until we have ROSC. So this patient, cardiac tamponade, unfortunately, is going to die on scene. If you suspect cardiac tamponade, you can transport. Just remember, pushing the chest in a moving vehicle becomes dangerous. That is going to be problematic. How many of you have ever come to a hospital and the doctors do a needle cardiocentesis or a seashell thoracotomy? None of you have seen it, not even me. Okay, so the chance that the cardiac tamponade patient is going to be in a resus and the doctor is going to perform a skill to revive, it's not going to happen. It's going to be rare that it happens, but it's not going to happen. Okay, so we don't check for cardiac tamponade. The other H, we addressing hypovolemia. Okay, so IV fluids. So now we have to stick a patient with a needle to get IVs up. So ILS, while your basics is running, the chest compressions, the ventilations, you start IV therapy. So now, what IV fluid are we going to run? So the idea now is ringers. If you have access to Plasma-Lyte, then Plasma-Lyte is preferred. But the rest of the world will run blood on these patients. Okay, so we have the option, ringers or Plasma-Lyte. So that is our patient, fluids. Okay, so that is addressing hypovolemia. Do we suspect hypovolemia in a trauma patient? Always, because he's bleeding. Okay. So now you get to, and remember, HSNTs are addressed as we are doing chest compressions. Okay. Now, so bleeding is controlled, HSNTs are done, needle decompression is performed. Remember, bilateral needle decompression. And then IV fluids is up. Hopefully you have your ALS coming on and he can start administering whatever medications he needs. Preferably now will be TXA and depending on what rhythm is on the monitor, antiarrhythmics or adrenaline treatment. Okay, so TXA definitely will be advised for trauma patients which is actively bleeding. So if you get ROSC, then well done. Now we package, now we transfer. Okay. If you don't get ROSC, you're going to be here for a while until somebody decides this is done, and then we stop. So traumatic cardiac resuscitation in Namibia does not have good prognosis. One, because we run it like a medical scenario. It's not a medical scenario. We need to address bleeding. In these resuscitations, bleeding addressing is as important as chest compressions, airway, and breathing. Okay. Also, our capabilities. We are limited throughout the spectrum, and blood here will be beneficial to your patients. So, if your patient is hypovolemic, it's a hypovolemic traumatic cardiac arrest, then getting him to a hospital might do a difference. Okay? So these are things to consider. But post-COVID, we tend to move away from active resuscitation in the ambulance on the way to hospital. So ROSC on scene, then transport. Okay, so that is how we go through the algorithm. Questions from you guys? Everybody understands? Yes?
Okay. We talked about this in our previous CPD course with the failed resus.
Mm-hmm.
Okay, so I want to assume that if you failed chest injury for this patient,
If you get onto a resus event, traumatic event, chest impalement, you want to do chest compressions because the patient's cardiac arrest, you need to remove it. Okay. Think about it this way. You have one stab wound on the chest cavity, and if you do CPR, that object moving up and down, how many times does it stab now, whatever is inside? So remember, that's 120 compressions in a minute.
Okay, so we pull it out, chest compressions, and then
If there is a suspicion. On the side, preferred, yeah. Okay. Reason why we don't put it on anterior is because of a chest movement during chest compressions. Lateral is better. Lateral is also now proven to be less complicated and less risky for cardiac problems because people tend to stab a little bit low. So yeah, so on the side, it is less risky. Okay, great. Other questions? Udo? Okay, so our friend, which is the ILS here, you have 3 partners. Let's run this. The bag is outside the door. Okay, great. So just to confirm, you are 3 ILS, né? And 1 basic. Great stuff. So welcome. Okay, average way back in the Gramadulas of Windhoek call, you are dispatched to a stab wound. You arrive, your patient is man down, lying like this. People tell you the scene is safe. There is no interference. There's no cops yet on scene, but the security guard safe.
The security guard, it's safe.
Yeah.
Okay, so arrival on scene, apply PPE for me and my team. I request from one of my team members to phone for extra help and to get higher qualified, possibly a second ambulance with my advance. Is there any family members or friends?
Nobody.
Right. So the bystanders say the patient was stabbed.
Yeah.
So is there anyone that is currently with the patient that saw the incident occur?
Everybody's standing around.
Everybody. Okay, so can anyone exactly tell me what led to the patient being stabbed?
Argument, got stabbed.
Argument, got stabbed. Okay. Hello, sir?
No response.
No response. Can my team prepare for me so long airway management, and can I get pulse?
No pulse.
No pulse. Can one of my team members already start on CPR for me? As I do a head to toe, do I feel any obvious bleeding?
Okay, gotta stop you there. What's the first mistake you've done? Catastrophic bleeding. You immediately went into the medical resus protocol. Traumatic now. So you should have checked for catastrophic bleeding. Okay. Good. Start there.
Okay. Catastrophic bleeding. So, do I see any pool of blood?
You notice a pool of blood to the right shoulder side.
To the right shoulder side.
But nothing on the anterior chest.
Nothing on the anterior chest. So, which believes me to nothing on the anterior chest, which leads me to believe it can be on the posterior side.
So how do you find out?
So can I have 2 of my teammates to perform a log roll, please? Can someone come assist, please?
Help me turn Sniffany.
Okay. Udo, can you hold C-spine fast?
And then on you.
Okay.
Okay. 3, 2, 1.
As I feel on the back, do I feel any open injuries or do I see any open wounds?
Stab wound, center chest, between the shoulder blades.
Okay, stab wound center chest, then that would conclude to be a 4-sided chest seal or 4-sided
Okay,
dressing.
you have a chest seal there.
Yeah.
Just stick it on. Okay, great.
All right, Uru, you can place patient back.
Okay, 3, 2, 1.
Okay, and on that, with that, is there any other sources of bleeding from my
No,
patient?
nothing.
Nothing from that. Okay, on that, do I see any chest rise and fall
Nope.
for breathing? Can teammate insert OPA and start on PVM? Further than that, catastrophic bleeding, airway, bilateral chest decompressions will be then done if to rule out HSCTs.
where?
Since to avoid if we have to do CPR at the moment, which we'll have to, so it will be mid auxiliary.
Okay.
Then with the BLS providing the BVM, I will request the ILS to perform the decompression, and then I will start on CPR.
Okay. What else can you attach?
ECG monitoring to get the precise
Okay, you have a PA bradycardic rhythm.
PEA bradycardia. Also electrical activity bradycardia. What's the beats per minute?
35.
Also have one of the ILS start IV for me, trying to get extra fluid into it.
Okay, which fluid are you gonna run?
We will run Ringer's lactate, if possible bilateral.
Okay. Okay, just for exercise, your IV is up, it's running.
The decompression,
Mid auxiliary.
Okay. Eldrin, what needle?
14 gauge.
Okay.
Linear,
It's a line.
cardiac tamponade. What are the one of those listening with what are the HHs? Yes, please.
H's and T's, not HET.
I know.
We are basically
Hypovolemia is
Okay. Hypovolemia, bleeding is controlled.
with IV fluids being attached.
Okay,
is
so hypovolemia.
tension released.
Needle decompression, no air escape.
Okay, let's check the other side.
So it was IV controlled by bilateral sides.
Okay, no air escape.
No escape. Okay, so it can be left as is, and then transport. Get patient packaging.
Okay, you have a monitor, PEA rhythm, no pulse, you've
Yes,
decompressed,
CPR.
what's your next step?
Start CPR.
Okay, somebody needs to start pushing the chest.
1, 2, 3, 4, 5, 6, 7, 8, 9, 12, 13, 14, 15, 16, 17.
Okay, now for the whole group, start thinking. Stab wound, middle of the shoulder blades, center mass. What is the injury this patient might have? Cardiac tamponade. Okay, because location and penetrating wound. And you just decompressed, no air escape. So there might be a cardiac tamponade happening here. That now becomes your decision. Are you going to stay on scene, resusc till you get ROSC, or are you going to load and go? Depending on service you work for, but yeah.
1, 2, 3, 4, 6, 8, 11, 12, 13, 14, 16, 17, 18, 19, 21, 22, 23, 26, 27, 28, 29, 30. Last cycle. 1, 2, 3, 4, 6, 7, 8, 9, 12, 13, 14, 16, 17, 18, 19, 21, 22, 23, 26, 27, 28, 29, 30.
Okay. So while you're doing CPR, let's say your rhythm changes. You've now been doing 2 minutes of CPR. Your rhythm changes from the PA to VTAC, ventricular tachycardia. Still pulseless.
Still pulseless, that would then necessitate shocking.
Okay, so Jules?
Since there's no one on scene to provide me any details of the patient,
It's
I
an
will
adult.
start with 200 joules straight.
Okay. So, okay, thank you. Well done, everyone. Okay, just remember, changing from medical resources to trauma resource approach. So it's bleeding, airway, breathing, chest compressions. And with chest compressions comes ECGs, ne?
Quick question.
Yes.
Do you still have 30 or do you just ventilate it in 5 seconds?
No, because this is basic airway, so it's synchronized 32. The moment advanced airway, then it changes to asynchronized. 1 breath every 6 to 8 seconds with continuous chest compressions. Okay, guys, just leave a kit, just grab a seat. We just had. So basic airway, OPA, NPA, synchronized, asynchronized CPR. So with a basic airway, we're still going to do synchronized. 30 compressions, 2 ventilations, okay, until more advanced airway is placed. So LMA, iGel, King LT, ET tube, whatever device is placed, then it changes from synchronized to asynchronized with 1 breath every 6 to 8 seconds and continuous chest compressions. Then the chest compressions just goes for 2 minutes at a rate of 100 to 120. After 2 minutes, change compressor. Now, slightly change in your scenario you just had. You get to this patient, same patient, but when you put your leads on, the patient is VF VTAC, okay, ventricular fibrillation, or ventricular tachycardic. So it's a defib situation. Do you defib immediately or do you delay defibrillation? Okay, in a medical patient, that's the correct answer. In a trauma patient, you want to do 2 minutes of chest compressions. Why? You want to get blood to circulate through the heart to make sure the heart has blood in the moment you defib it. Saying goes, we don't want to defib an empty heart. Okay, so traumatic resources will be 2 minutes of CPR, then defib, where medical will be as soon as possible. Okay, that's AED, everyone. So remember, if you use an AED, the basics, or the ILS has an AED, even if that AED constantly tells you, shock advised, wait your 2 minutes before you defib. Okay. So at 2 minutes, if it still says shock advised, then go for it. Okay. Manual at 2 minutes, that will be your defib protocol. So you have done your catastrophic bleeding, airway is sorted, breathing is sorted because you're ventilating, chest is decompressed, your HSNTs is sorted out, chest compressions is happening, you defib. So the first 5 minutes of a traumatic event, that will be the trauma arrest. After that, after your first defib happened, everything is in place. Then it synchronizes with a medical resus, which becomes 2 minutes defib, 2 minutes defib, 2 minutes defib. Then resus stays resus. It's just the initial approach on a trauma that changes from a medical approach. Okay. Questions? Udo? Okay. So Let's do this again. Elrin, you are the lucky winner. You have, again, 3 members as a teammate. There's your bag. Let's run a quick last one. You arrive on scene. Guy is stabbed left clavicle in a downwards direction. On the ground, pool of blood, left shoulder to head. And are you ready?
Yeah.
You there?
Okay, arrive on scene, PPE problems, call for help, hazards are clear.
Hazards is clear.
Cool. Please get the jump bag, ECG. Okay, I need a bandage because we see there's obviously bleeding. Does my patient respond on hello?
Nope. No response.
How's the airway?
Airway is clear.
Okay. Breathing.
No breathing.
Okay, please get on the bandage. Okay.
No pulse.
Okay. Please stop pulse. Focus on. Okay. Yeah. Chest compressions. Quickly attach the ECG for me. Okay. Can I get a pulse? Okay. Is the bleeding stopped?
Left clavicle, ne?
Sorry, my bad. Okay. Bleeding stopped?
Not with a bandage, no.
Okay. No. I stopped the video.
Say again.
I stopped the wound.
You're gonna pack a chest wound.
Oh, it's a picture. Okay. Let me get this. Okay. Is the injury only in the front?
Left clavicle. Your other left.
Yeah.
Okay, so chest seal is on.
Okay, please put that on ringer ID for me. Okay, could you give me chest sounds?
You want to listen chest sounds on a patient that is being chest compressed.
It's not gonna work. Okay, put that IV. EVM.
Okay, your monitor is up and it shows asystole.
Asystole.
Yeah.
Okay. I'm not gonna shock. Can't shock an asystole. How long penetrativity obvious?
From time of call received to you arrive was 15 minutes. And you are now on your first cycle.
Let's quickly do another cycle. Okay, HSPTs, hypovolemia.
Yeah.
Okay, is that my IV up yet?
No. Okay.
My IV up?
IV up. Just remember where you put that needle.
Okay. Fluids, that's running.
Fluids is running.
CBC. Okay. ECG. I don't have a bleeding. Okay. How's my pupil?
Pupils is fixed and dilated.
Fixed and dilated. Okay, I'll just stop.
Proper easy grip.
Fixed. Dilated, right?
Yeah.
Okay, guys, stop.
So you're declaring.
Yeah. Asystole, fixed dilated pupils.
Okay. What is your declaration protocol?
So, gag reflex.
Okay.
No gag reflex.
Obviously, OPA is in, so it doesn't
okay, my
gag.
ECG already shows the asystole.
So how do you check your ECG to make sure? Remember, lead 1, lead 2, lead 3.
Yeah.
All 3 leads needs to show asystole. And remember, you cannot just say a rhythm is asystole. Increase amplitude on your monitor because you might have a fine VF. So then you declare on a fine VF. So remember that. That's why I give it, to teach you something new. So before you declare on an asystole, medical patients also.
Always 5 cycles.
Always. No, you can, it's 15 minutes down. Try for about 15 minutes before you declare. But before you declare on an asystole rhythm, just increase the amplitude to make 100% sure that it's not fine VF. Okay. Some monitor shows fine VF a little bit bigger, some doesn't, depending on brand.
So that's we put up the monitor before we touch the patient.
No, while you're doing CPR. And when you analyze, obviously just stop for about 10 seconds and yeah. Okay. So remember, easy grips, ne? Okay. Any questions from you guys?
Let's not be posted. Please.
This is how you learn. So this is how we learn.
Okay, Stephanie.
Remember?
In real life, it's going to be a bit more hectic.
Yeah,
Definitely.
obviously, because you're like, okay, obviously we're with new people and people don't understand, and like your family, because you have your own law people as well. And
1, 2, 3 ILS. Just saying. Okay. So, but this is why we're here. So we learn a new thing. We learn a new.
Okay, so there is a thing of okay.
Yeah, you can still. Great.
We have noticed we had the same problem. Me and Mr. Mike went on the spot, responded 10 minutes, and then we ended up at getting the patient, you know. But they already had fixed bilateral. So
Okay.
that's
Unfortunately, just grab a seat quickly. When it comes to the resus protocols and things, because we have a very low population that wants to do CPR. Our CPR capability is limited. Okay. Average response time, 15-25 minutes, depending where you are in Windhoek. This is not even out of Windhoek. This is just in city Windhoek. So you're going to get on a scene. The patient might have been deceased since this morning. The patient might have just collapsed. The patient might have been conscious until your ambulance stopped there and then went bye. Okay, so that's why one of the history questions to the family, to the bystanders, how long was he not breathing? Okay, and here we don't ask how long he's not having a pulse. How do they know he doesn't have a pulse? Okay, but since when is he unconscious? Because unconscious associated, you can relate to not breathing, so he's been 5 minutes. So there's still a time for saving, for reversing. Okay? So there is a possibility. Obviously, the longer this process is, the smaller your chance get to reverse. Just to correct also one mistake. No, we fixed it as we went through. And this is why we fix and go. When we do breathing checks, we don't look, listen, feel. We literally sit on an angle, check, chest rise. We don't come to the patient's mouth because he coughs blood, he coughs hepatitis, he coughs COVID. Well done. Guess who is the next people in isolation? Okay, so for the guys who had COVID, isolation is not something new. For the guys who didn't have COVID, take your PlayStation with. You're gonna get very bored. Okay, so yeah. So on that note, questions from you guys?
no, this is medical.
Okay, just hold on that. Jadine?
Say now, for example, on transportation with your higher qualified, if your higher qualified is on the bus with you, can the higher qualified then set the ECG or the defib on a pace?
No, pacing is done when the heart is beating. And then we assist the heart to beat better. But there's a whole protocol before you get to mechanical pacing. But that's not happening in a traumatic patient.
Another question was,
Rosk.
Yeah, Pearce. So after that, do the patients include the shield?
They either wake up completely to the point where they talk to you, or they start breathing and have a pulse and still unconscious, or they just get a pulse and not breathing. So the moment you get ROSC, you start again at hello. So hello, easy responding, then airway, is the airway maintained, easy breathing. You might need to replace BVM with a mask. You might not breathe, so you keep on ventilating. Then it goes from CPR ventilations to 1 every 5 to 6 seconds, depending on adult, child, infant.
Okay, no, because we never had a.
Welcome to my world.
I asked you this last week, but it might be interesting to the rest about transporting deceased.
It's a debate going around. Some services will transport the deceased, but then it's an active resus. So we're not going to put a dead person in a plastic bag to the hospital. That's NAMPOL's department. Yeah, that does create an ethical. It happens, but it creates an ethical problem.
About 2015, 16, roundabout, while I was still a volunteer for the others, we actually had to wait 2 hours for an ample to arrive.
It's the bad bite. Unfortunately, if you are the junior qualified, the newbie in the situation, you tend to get left on scene and the ambulance goes to another call if there's a call in, and you sit there with the family and the deceased. Transporting deceased in Windhoek, from my experience, coming from rural, you needed police permission to transport the deceased person. Because they want to know why, what, how, when, is there foul play, all that. And the moment you move a deceased person, you're destroying a criminal scene. So we don't tend to transport. We have already destroyed these people's scenes with our resus attempt. So yeah. Okay. Unfortunately for the newbies. Okay, yeah. So, but that does become a debate. Yeah. Okay, any other questions? Okay, quickly, recap. So, you are dispatched, trauma patient, arrive on scene. So, hazards, is it safe? History, quickly, what happened, because that will determine trauma or not. Hello, determine level of consciousness, patient is unconscious, help, higher qualified, police, fire brigade, whoever is needed for that situation. Then check for catastrophic bleeding. And with catastrophic bleeding, you will now control when found. So please, when we check catastrophic bleeding, it's not always standing there and looking. Yes, that's the initial one. Look. Do you see pools of blood? Do you see clothing being wet? Remember, dark-skinned jeans tend not to show blood or wetness, so you need to pat the patient. So quick, head to toe, very rapid. So you found the bleeding, control it. Wound packing, junctional areas, please, head, chest, abdomen, pelvis is not packable areas. So either legs, junctionals, that's your legs, arms, junctionals, that's your packing area. Neck, you can also pack. Just be careful if you pack the neck so you don't cause airway obstruction. Okay. Remember, if you stick your finger into the hole, you stay there until surgery. Okay. Just so that you know. Don't stick your fingers in holes. Okay, so after bleeding control is done, you get to airway. So airway, open, OPA, NPA, advanced airway, depending who's with you, who's on the bus. Then breathing, start ventilations, oxygen 15 liters per minute, off you go. Check for pulse, no pulse, start chest compressions. While chest compressions is happening, your BLS, your ILS partner, whoever starts attaching your leads. Okay, leads up, 2 minutes of CPR, then analyze. With analyze, depending on rhythm, PEA, VF, VTAC, so shockable, non-shockable, shock or continued chest compressions. In your first 2 minutes, while you're busy with chest compressions, start checking HS&Ts. HS&Ts being hypovolemia, hypoxia, T's being tension, and cardiac tamponade. Cardiac tamponade tend to be the one we skip because we are not able to treat that adequately. And then we have done our trauma cardiac arrest up until that point, and then it merges to 2 minutes CPR, defib, if shockable. If non-shockable, continue chest compressions until you get ROSC or until decision is made to declare. Okay. Remember, you guys are ILS. You have a capability to declare. Just remember to follow the declaration steps. Okay. Don't just say he's dead. Thank you very much. Okay. And remember, before we declare, about 10, minimum 15 minutes of resus efforts. Okay. Remember, isostole can reverse back to a perfusing rhythm. Okay. Trauma resusces, definitely bilateral IVs. If indicated, needle decompression. If not indicated, don't decompress. Okay. So when will you perform a needle decompression? Any suspicion, MOI to chest injuries, indicative of pneumothorax, tension pneumothorax. Okay? Everybody happy? Good? If you have no more questions, please sign the attendance. Okay, good. Thank you for coming.